Red days. That's fine.
So, the thyroid gland, which is a part of um, the endocrine system. So the thyroid gland will secrete hormone that will regulate the basal metabolic rate of the body, and two hormones that are secreted will be the thyroid hormone and the calcitonin. So the thyroid hormone is two types, the thyroxine, the T4, and the thyroxine, which is the T3. So when you look at the lab, they are looking at T3, T4. Okay. So these are the two hormones of the thyroid hormone, and then the other thyroid gland will also have the calcitonin, which regulates the calcium for storage in the body. So the source of the thyroid hormone can be also, as we established, it can be hypo or hyper. It could be over-secretion or under-secretion of the thyroid hormone. Or there could be a problem with the hormone that stimulates the thyroid gland to function, to secrete this hormone. So it could be that thyroid operation in thyroid stimulating hormone, which is just there to help the thyroid gland, to remind the thyroid gland to do its job. So there could be a problem in that hormone. So when there is low thyroid hormone, and that one of them could be from inborn, the child is born with that low level of thyroid hormone, and that's referred to as hypothyroidism. And this is basically a problem that results from inborn during development. If anything that happened during that sensitivity period in fetal development, that can affect development of the thyroid gland. So the thyroid gland fails to develop. And with that, there is a malformation of the thyroid gland, and that consequently will result in under-secretion or under-production of the hormone. So some of the causes that have been identified will include any mutation in the gene or inborn errors or any disorders of the fetal gland can affect it, or failure of the central nervous system thyroid gland feedback mechanism to form or to complete. So that can lead to low production of thyroid hormone. Some of those disorders can be a consequence of maternal inborn. Remember, when you have in pregnancy, you screen the mother for infectious diseases, including rubella, rubiola, and all that, including thyroid hormone, including anything, especially that will affect that maternal transmission of that, that can affect inborn development of that fetus, can result in that deformity. Something like maternal transfer of drugs, like lithium, can lead to hypothyroidism, or even when the mom is taking um, thyroid hormone, okay, or there is an antibody blocking that, or any effect, deficiency of iodine in some nutritional deficiency of iodine that is common in some geographical areas that can also affect the developing fetus. So again, as with anything that we'll do, we'll like to get a good history of the child's condition. Because it is a congenital problem, we need to get a comprehensive prenatal history of the mom. If during prenatal, intrapartum, and postpartum history, we need to get that in addition to family history. When we examine the child, thyroid hormone, which says aids in the metabolism of the body. It helps to maintain the basal metabolic rate. It helps the child to maintain their activity level and their function and their alertness. And because there is less thyroid hormones, all those activities, all those functions that will be heightened by the effect of the thyroid hormone, they are lacking, so meaning that the child will become lethargic, the child will be sleepy, the child will be sluggish. In fact, if you think of hypothyroidism as the consequences of it, or the symptoms will be sluggishness. Everything is slow. Heart rate is slow, metabolism is slow, muscle tone is slow, child is so sleepy and droopy, all that. Okay, so if you think of it that way, including the peristaltic movement is slow in the GI tract, resulting in that child having constipation because the peristalsis is not moving as it should, so it's not moving the fluid and secretion, so the stasis of those in the GI tract, resulting in overall constipation in the child. So when we do our screening, the first thing, one of the things that you know already would be to do newborn screening. Kevin, Eric, and who is next to Kate? Liz. Liz. All right? Thank you. So we do newborn screening, and that's part of their PKU screening in the lab, in their immediate newborn. Before they go home, they do that PKU, and part of it will be doing testing for hypothyroidism, sickle cell anemia, thalassemia, and all that. So you know that will be the initial screening. And once the child is identified as having potential problem with the thyroid hormone, they need to go to a center, a different center to be managed. Early detection, early follow-up that will prevent the other consequences of this and the immediate, throughout life. Now, when you look at the blood, when you do the blood work, you look at the T3, T4, they are all low due to that hypersecretion. When they do a thyroid scan and or ultrasound, they may be able to find maybe a tumor or something that is pressing on the thyroid gland, or that it's affecting the thyroid gland, or maybe looking at it and they say, oh, the thyroid gland did not even develop at all because this is congenital. It's hypo, or it's hypo, it didn't develop at all. So you may not see that, or you see it, it's not fully developed as we would like to see. So again, if it's congenital and you identify that in that child, of course they cannot make the thyroid hormone T3, T4. Our choice will be to give them the hormone, to replace that hormone in order for them to maintain their basal metabolic rate. Otherwise, the child will be hypotonia, muscles will not grow, they cannot utilize any, nothing, they're just there, and the consequences of the complication will be so much for them that the child may not be able to maintain optimal health. So you give the thyroid hormone, and that hormone needs to be monitored and be given to this child appropriately. So we need to teach the parents how to give the hormone. So for a child that has hypothyroidism, we need to promote and monitor growth of that child. We need to promote adequate rest period for this child. This child is constantly weak and lethargic, so we need to promote rest. We need to monitor vital signs of the child. In essence, we need to look at those signs and symptoms of hypothyroidism. And also we need to monitor for signs of hyperthyroidism because we are giving this child Synthroid. So we need to identify when we are overdoing it, side effects. When the child starts to get jittery, hyperactive, or vomiting, we need to know that as well. We need to educate the family. One thing that has been known with thyroid hormone is that soya bean affects the absorption of thyroid hormone. So when we're advising on the choice of formula, we would advise the parents not to use soya-based formula, just for this particular child that is taking Synthroid. They need to come for their follow-up. And part of their follow-up, we are monitoring the levels of the thyroid hormones, and we are adjusting the dose of the thyroid, Synthroid or thyroxine, based on the result of the blood work. And then because this infant is hypotonic, we have to send this child to the high-risk pediatric centers for them to do the infant stimulation. Because this infant has hypotonia, they run a very high risk of having sleep apnea as well. And they are so flabby, so we need to kind of monitor them and go take them to the stimulation center for them to be followed up, in addition to going to the regular pediatrician, going to the regular endocrinologist for appropriate dosing of their medication, appropriate childhood maintenance, including the immunizations, and follow-up for regular pediatrician, and then the stimulation center. Any questions on that? Okay, so that would be, yes.
Can you clarify the formula? What is a contraindicated for people who are taking Synthroid?
Soya-based formula. Soya milk, extra white milk. Yeah. You know, in infants, we have Prosobi, we have one other one that is soya-based. Any soya-based formula, they cannot take it. So you advise to give them, because some parents will choose to give the soya-based one, like the Prosobi. Prosobi is made by similar. That's another one that I'm forgetting them here. There's a lot of them that has soybean formula, so there will not be no, isobil is similar, Prosobi is by Enfamil. Yeah. And these are all soya-based formulas, so they cannot take those ones. Okay. All right. Any other questions? Okay. So the hyperthyroidism, on the other hand, will be that excessive. Like I said from the beginning, anything that happens in the endocrine system is either too much or too little. So the too much of this thyroid situation would be the Graves' disease, which we see this 12 to 14-year-old, which is just their peak age, that you see it. So it will be the adolescent disease. However, you may see it in infancy also. It's also immune response to the thyroid stimulating hormone receptors. But the specific reason that is happening, has not been identified. It's still up in the air. So let's work on what is really happening. But there is an enlargement of the thyroid gland. And as part of that enlargement of the thyroid gland, you see that on the next slide, you see that big swelling that will accompany the protrusion of the eye walls or the exophthalma. Exact. So protrusion of the eye. Again, the diagnosis here would be, you look at your T3, T4, it will be high. In hypothyroidism, our T3, T4 is low, but here our T3, T4 is high. And then in this particular case also, there is suppression of the thyroid stimulating hormone. Because the suppression affects the response of the thyroid stimulating hormone receptors. Okay, so the thyroid stimulating hormone is less, and the T3, T4 level is high. But on the other one, T3, T4 is low. Okay, so again, management is, as the cause of it is controversial and it's not specifically known, the treatment is controversial as well, especially pediatrics. So, but the growth, the overall goal would be to slow down that hormone production, as we would in any other thing that is over-secreting. So they will have to give anti-thyroid drugs, commonly the PTU, and their metamazole. Those are the two chief points that they will give. Or they can do surgery to remove part of the thyroid gland. They do a subtotal thyroidectomy followed by radiation therapy. So, depending on the endocrinologist that is in charge of the case, will determine what is the line of treatment that he will elect to go with. But these are options that are available. One thing that we need to be mindful of would be that thyroid toxicosis, which is that sudden release of the hormone in the body. This is quite unusual in children, the little ones, especially we are dealing mainly with hypothyroidism. And the only time you may see that is maybe if you, for some reason, you do a double overdose of that thyroid hormone, you see it in the baby. However, for the adolescent group, yes, and adults, you can see this happening to them. And infection or sudden stress can predispose the child to the condition, or if they are not compliant with their anti-thyroid therapy they are taking to reduce the level of the thyroid hormone. If they are not compliant, they are not taking it, or they stop it abruptly, that hormone level can rise suddenly and the person can go into thyroid crisis. And what do you notice? The person will be very restless, very irritable. You see severe tachycardia, accompanied with symptoms of diaphoresis. Remember, when the heart is just racing, it's not allowing enough time for the heart to polarize and for the heart to move blood to the entire systemic circulation. All it's doing is just doing like this, but being very inefficient, so you end up with systemic failure and diaphoresis, and the person can just collapse from there. So, management of that will give propranolol or Inderal to decrease the heart rate, and then we would also like to decrease the level of that antidiuretic hormone by giving the medication. PTU can be one of those, can give that. One thing we need to do would be to do a good vital signs and monitoring of the patient, because we would like to identify those patients with hyperthyroidism. We would like to note their signs and symptoms. And when we are taking care of them, we don't want them in the middle of the unit where all the activities, all the noise, everything, centers around. And this is not a patient that we can go in and out of their room at will. You need to keep them in a quiet room. You don't want to over-stimulate them. And we need to promote rest in this particular patient. Again, we need to educate the patient and the family. Now, looking at this, you know that the target group we have here is the adolescent group. So we need to involve them in their treatment, in their education, make them part of that planning so that they can own up to the management of their disease condition. Again, we have to give adequate diet, increase calories. Remember, with the hyper and over secretion hyperactivity, this child is burning off excessive calories, excessive energy. And if you don't replace or report to the expenditure, over time this child will be losing weight. So we have to give diet enough to maintain that metabolic rate. And then we need to tell them about the side effects of the medication and all that they're doing. So, looking at this, you have this chart in your thing. I just brought it up here for you to look at signs and symptoms of hyper and hypothyroidism. If you look at these symptoms, you'll see that the hypo, everything in the hypo is slow, everything in the hyper is heightened. Okay? So if you look at sluggish, cardiac, constipation as a result of slow motility of the GI tract, cold intolerance, weight gain because the child is just sitting, nothing is happening, so the child is gaining more weight, as opposed to the child is losing weight due to that hyperactive and over expenditure of energy, and then decreasing growth because the child is not, that has really nothing for that child. Everything is slowed down. You can see decrease in growth here also due to that expense of that if you do not give adequate food and nutrients to equate the expenditure, then you can see decrease in growth and weight loss on the other on that side as well. Any questions on those two? Now, on the adrenal functions, you're looking at the adrenal, the gland, cortex will secrete steroids, and those steroids, you have the glucocorticosteroids, the cortisones, you have the aldosterone, and you have the sex steroids. Of these steroids, they are available to maintain the function of the body. And when there is an alteration in those steroid production, then you start seeing some problem. As you see the congenital adrenal hyperplasia, or you will see excessive in Cushing syndrome and or Addison's disease, you have problems. So taking the congenital adrenal hyperplasia, of course this is an autosomal recessive disorder. There is a deficiency in the cortisone 21 hydroxylase enzyme, which is needed to for the synthesis of the cortisol and aldosterone aldosterone. So for some reason there is a problem. It's not efficient. There is not enough. So what you will see is that you start seeing abnormal genitalia, overgrowth, and also you see accelerated growth. When you look at the X-ray, you see over advanced bone age. You can see premature closure of the suture line for the epiphyseal plate in the long bone. So the growth is retarded in length prematurely, and then you start seeing very much overgrowth of the genitalia. That you look at a female patient, you look at the clitoris, it looks almost like the size of a full developed penis. And then that's the time you start saying, is this a boy or is this a girl? Then, but by the time they do their ultrasound and also, do their effective evaluation and including their physical assessment, they'll be able to say, yes, for sure, this is actually a girl. But because of that overgrowth, this is so what the treatment, of course, would be to give hydrocortisone which is lifelong for most of the children. And then again, we need to educate the patient. Again, we would like to monitor for signs of acute adrenal crisis, which will include persistent vomiting, dehydration, low sodium and high potassium, hyponatremia, hyperkalemia, hypotension, tachycardia, and possibly shock if we fail to identify any of the earlier signs and symptoms the person can present. Again, as with other hormone therapies that we're doing, they need to come for their follow-up appointment, and they will also need to monitor their blood work closely and to be able to titrate their medication appropriately. So they need that education and support from us. Okay. So, as with our thyroid crisis, we can develop adrenal crisis. And this will result from hemorrhage or very severe acute infection or sudden withdrawal of steroids. You will recall that a patient that is taking steroids, for example, the patient with asthma that we put on steroid, or the patient with nephrotic syndrome that we put on steroid, when they're going to discontinue the steroid, they taper the steroid down. The physician cannot just come in one morning and say, DC Prolon or DC hydrocortisone, just like that. No, they have to do a stepwise tapering until they finally wean the person off from the medication. So if you do that, if you do not do it that way, stepwise, then you run the risk of putting the patient into adrenal crisis, and that patient can, present with irritability, headache, nausea, vomiting, hyperpyrexia. The temperature could be up to 104 sustained per time, with tachycardia, cyanosis, and possibly seizures in the newborn. Because anything that irritates that cerebral vessel, cerebral tissue, and with the seizure, with the high fever, can trigger seizures in the newborn. Okay. Again, what we would like to do is to give their cortisol and fluid replacement, and also monitor their vital signs, and we want to put in place their seizure precaution for the child. This one is one thing that you all are familiar with. It is a syndrome. It is not one disease entity. So it is a syndrome. It's a group of it's a condition that will occur when you have excess cortisol circulating in the body, and the patient will develop, very round cheek, very fat, retaining fluid, have all these pendulous abdomen and characteristics like they are all just like a balloon. With that, even though they look so fat and look so healthy, but everything underneath is just falling apart. Their skin is falling apart. If they have a wound, they cannot heal that wound because there is no tissues and nutrients and oxygen and everything that can heal that wound. The skin is not healthy, although it looks so chubby, but it's not healthy. So again, for this condition, you do the um, um, diagnostic test. You would notice there is excessive cortisol level in the blood. They can also isolate that in 24-hour urine collection, do a serum electrolyte and fasting glucose to do that. When you look at the x-rays of the skull, you see there is that enlargement of that cellular tosika in the brain. The bones are so brittle as well. So their treatment will be, if you identify any problem, like a tumor or whatever, we'll take the surgery, and then we'd like to treat the underlying cause. So whatever the cause is, we can treat that cause. We can use growth hormone, adrenocortical hormone, thyroid hormone, or any of those. And then after we treat that, steroids, again, we would like to withdraw steroids. One thing you should know about steroids in children also is that it affects their growth. In addition to causing decreasing their immune system, immune response to infection, it affects their growth, it retards their growth, so you have to monitor the growth of a child that is on long-term steroid therapy. Okay, any questions about thyroid? Okay, so we go to the last one, which is the pituitary, pancreas, and this is like a big time review for you because we did diabetes in med surg 2, and we're only highlighting the classic differences that we'll find in children. Again, diabetes will affect, it's a disease of the pancreas. The islets of Langerhans in the pancreas will, secrete those insulin. The alpha cells produce the glucagon, and the beta cells will produce insulin. Okay, and then we also have the delta cells that produce the somatostatin, which is believed to regulate insulin and glucagon. Okay, so any dysfunction of the pancreas will result in diabetes mellitus, while diabetes insipidus is posterior pituitary gland. Diabetes mellitus, dysfunction of the pancreas. So we have diabetes type 1, diabetes mellitus type 1, which is an autosomal disorder that occurs in children. It can also result from viruses or environmental toxins. Anything that happens in that sensitivity period of development, and it affects the development of that child, the development of pancreatic at that time can lead to that disorder of the pancreas. Type 2, so in type 1, there is absence or not enough insulin. In type 2, the pancreas is normal, produces insulin, but for some reason, there is a resistance to that insulin, or that insulin is not adequate to maintain the function of the body. So, with type 2, we associate type 2 with overweight. In children, we know that type 2, original thing we know is that type 2 is strictly restricted to adults. But now we are seeing more and more type 2 in children. So type 2, we associate it with overweight, and also the risk factors, which will include family history of a parent or a relative that has type 2 diabetes. Usually we'll see type 2 in children age 10 and above. And then we have more in African American, Native American, Latinos, and Asian children. They are all affected by more with diabetes. However, these days we are already now, reports that are coming up already seeing almost a comparable number of Caucasian children with diabetes. How we are shifting everything these days is just unbelievable. I think maybe because we are more vigilant and keeping the numbers, or whatever that is, or more advances in the way we identify things, that we are already seeing more of the things in play. So, but anyway, with diabetes as a whole, be type 1 or type 2, what is happening is that once there is a deficiency of insulin, the glucose that is circulating in the body is not able to get into the tissue for that tissue to use it for metabolism. Because the chief job, the primary work of the insulin is to be that messenger, is to be that carrier of the insulin. Will just carry the glucose from the bloodstream, deposit it into the tissue for tissue to use that glucose to metabolize. When the insulin is not doing its job as it will, as it should, then now you have excess glucose in the bloodstream. And once you have that excess glucose in the bloodstream, that's your hyperglycemia right there. Because you have excess. The insulin is really lazy and didn't do its job because there is not enough, as in type 1, or in type 2 there is enough, but for some reason there is that resistance of insulin, or something is preventing that insulin from doing its job the way it should. So now you have excess of glucose in the stream. Now, with that hyperglycemia, that's a lot of glucose in the bloodstream. In the kidneys, on the other hand, you start seeing the function of the kidney diminishing as well, because the kidney is not getting enough to function as it should be. Now, kidney is having a hard time keeping up with all the excess glucose in the bloodstream. Because it's not keeping up with all the excess glucose, now you start seeing those glucose seeping out in the urine. And that's how you get the glucosuria. Because the glucose is now too much and the kidney is so much overwhelmed from keeping, keeping track of it, that it's allowing the gate is now left open, that okay, I can keep some of you, but some I'm not able to hold you, you can just go. Okay, I will not check your ID pass, you just continue to move on. So now you see the glucose in the urine, and that's your glucose urine. So now glucose is not getting into the tissues to be used for metabolism. The tissues are starving very much. They are hungry, but they cannot get the food. And then the cells will say, you know what? Why will I sit here and starve? Let me eat up what I have already in my stomach. And then that's how they start utilizing the already stored fat and protein in the body. And that's how they use that to convert that. They break down protein and fat to make their energy. Okay? With that constant breakup, especially with that breakup of fat, that's when you start seeing those ketones. Both the ketones in the blood and ketones in the urine. Okay, so you have that ketonuria, or you have that acetone smell of the breath that you see, especially in the face of diabetic ketoacidosis, which is something that brings majority of the pediatric patients to the ER, and that's how they are diagnosed for the first time. Because they have no clue they have diabetes until they come into diabetic ketoacidosis. So that's basically what happens in any type of diabetes, mellitus, and basically that's it. So how do we diagnose it? We do random blood glucose. Anything above 200 with signs and symptoms of polyuria, polydipsia, and polyphagia. Another criteria would be doing a fasting blood glucose that is equal to or more than 126 milligrams per deciliter. Or we can do a 2-hour plasma glucose level. When we do the oral glucose tolerance test, and you know that you covered that when you did the stationary diabetes and you're doing a glucose tolerance test, you have to draw the blood, give them the glucose to drink, and then you treat the blood and look at the blood level. So we do that and we find more than 200 milligrams during an 2-hour oral glucose tolerance test. That would be a way to diagnose, another way to diagnose diabetes. Okay. Other tests we can do will include our CBC we did. We'll look at our UA where we see positive glucose in the urine, or we do our electrolytes, VIII and creatine and all that. We can do all that, to look at the function of the kidney. So here is basically comparative of type 1 and type 2 diabetes. Type 1 is insulin deficiency, type 2 is resistance of insulin. Type 1 have abrupt onset. Most of our pediatric patients do not know that they are diabetic until they show up in DKA. Okay. Type 2 is slow onset. Type 1 will have ketoacidosis. Patients are generally lean, normal looking, but they are also insulin dependent. So basically, they do not respond well to oral glycemic agents, which those in type 2 will respond to very well. And usually our type 1 patients are very, very young. You can see someone as young as 3 months or even younger that has type 1 diabetes. While in type 2, we are looking at our teenagers, 10 years old and above, who are obese, and our adult children. So again, for us to manage diabetes, it is a multidisciplinary approach that we have to take. And we have to, yes, we want all the disciplines, the pediatrician, the endocrinologist, the nutritionist, the nurse, the pharmacist, everybody in it, but the patient have to be the center. Patient and the family have to be the sole anchor of that management team. We have to get them involved, especially the adolescent ones. Get them involved, allow them to call the shots of what happens, but you have to guide them to call that shot. That way they will take ownership of whatever plan that you are putting in place, and for them to be able to follow through with the plan that you are telling them to do. We also need to involve the school setting, because this child will have to go to school. You have to notify the school that the child has diabetes and that the child will require, treatment. They need to be aware of it. They need to know about signs and symptoms of hypoglycemia. Parents need to know, child needs to know, everybody needs to know. Okay? This is not a thing that the child will say, oh, please don't tell them in school, I don't want them, I want to keep my business private. No, you don't keep your business private. You tell everybody just in case for safety reasons. Okay? So we need to monitor our glucose and medications, and also we have to include self-management skills for them to do. So I gave you some blood levels. If I'm going to ask you for any parameters, this is what I will hold you on to. I go by the American Diabetes Association number. So if I have to ask you anything, that's what I will ask you. I'll hold you on to. Another thing would be hemoglobin A1C would be to monitor long-term glucose level. Okay, it is individualized in that each patient has their own specific number. But this is the recommendation by the American Diabetes Association. They are requiring a level of less than 8.5, but no more than 7.5 in children less than 6 years old. And a child 6 to 12 will be less than 8, and for 13 to 19 will be 7.5. That's the goal that they want to see over a 3-month period. Okay? So again, this is treatment, focus on the treatment, what you will be telling them about their disease condition. This is the areas that you need to focus on. And this is more teaching that you will tell them about. And then more importantly, you're telling them about signs and symptoms of hypo and hyperglycemia. So this could be hypoglycemia, what causes it, and what clinical manifestations you will notice for each patient. And this could be a treatment of hypoglycemia. We would like to give orange juice, preferably milk or hard candy, and follow it with complex carb. And then if the child is unconscious, we would like to give glucagon. We do not give PO anything for anybody that is unconscious, or really woozy, you are not sure where that person is, because you are setting that person up for aspiration, so you don't want to even try that. And then you need to recheck the blood pressure, blood sugar. In the hospital, we would like to do the blood sugar is low. We can give D50, and then repeat the blood sugar, and then monitor the child very closely. But this is in the home, that's what we like to do. And all the patients should carry their hard candy and glucagon, yes.
Once you give them the, like say you gave them the juice or something, then when would you recheck the blood sugar? Something after you give it.
You wait a minimum 5 minutes to do that, minimum. And then again, looking at the patient's condition, in fact, you may even give that and the person is not doing well for you, we check it right away and then you are calling 911 because you are out in the field. Okay, this will be a hyper, and this is where we see most of our pediatric patients. That's when they come to the ER for us. See? Okay, and these are the complications. So now, another thing, so the diabetic ketoacidosis, of course, is a life-threatening condition. Some patients can present with the blood glucose level of more than 300 and above. Yesterday, we got a report of somebody that came with a blood glucose of almost 1,000. That is too much. Okay? So, and this is mainly, that's a problem. Okay? So, consequence of that will be with all the things that we described in pathophysiology of diabetes will also happen, including electrolyte imbalance and dehydration by virtue of that osmotic pressure. So there is that osmosis. So now that happens and there is dehydration, there is fluid, and electrolyte imbalance, there is hyperglycemia. So with that, our strategy would be to replace the fluid by isotonic solutions. What are our isotonic solutions? Normal saline is one of them. What else? What are those? Normal saline, Ringer's lactate. Okay. We add dextrose after we've stabilized. Initially, we are doing Ringer's lactate or normal saline. And then we would like to give insulin drip because our goal is to bring down blood sugar. Okay? And we run the insulin at a rate of 0.1 units per kilogram body weight per hour. Again, our medication is tied with the weight of the child. Okay? And then we train the child to prevent DKA. Now, these are some of the developmental issues that can happen with infants and toddlers and all the age groups for you to be aware of. For the preschoolers, so we're taking their characteristics and putting it in place as part of things that you need to watch out for. And that could be a problem that could pose a problem in their treatment or management of diabetes. Okay, and for early adolescents and adolescent groups, that's what we are looking at, and we have to put in place things that can help us treat those kids appropriately, but we have to make them the center, the focus of that treatment plan. Any questions? No? Okay, so. All right, so you all got your